present. I'd like to thank you for presenting Ancient University here in the South Egypt Cancer Institute conference. It's a prestigious meeting, and I'd like to thank the scientific committee for their kind invitation. I'm Mohammed Al-Imam Shawi, a lecturer of General Surgery, Colorectal Surgery Unit at Ancient University, and I'd like to present my talk today about the Mesenteric Mesenchymal Tumor, a report of a sporadic case and dilemma of its differential diagnosis. We have a 53-year-old male patient that was Hep C positive, otherwise medically and surgery free. He was presented to us partially obstructed with left upper quadrant abdominal swelling of 3 months duration, enlarging in size, as well as intermittent vomiting, colic abdominal pain, dragging abdominal pain, weight loss, and night fever. Family history was irrelevant. And on examination, he appears markedly emaciated with marked weight loss about 20 kg over 3 months. As regards the abdominal mass, it was ill-defined in the left upper quadrant, lumbar, and encroaching on the gastric region. It was deep to the muscles and slightly tender on palpation. There were no signs of peritonitis. As regards the labs, apart from high C-reactive protein, all the other labs were normal. We requested radiological evaluation, and pelvic abdominal ultrasound shows a huge midline mass with heterogeneous echogenicity, soft tissue and cystic areas, as well as foci of calcification. And apart from multiple sites, there were no other abnormalities. Chest CT study was free, and pelvic abdomen CT with oral and IV contrast was ordered. The upper cuts of the pelvic abdomen CT with contrast showing a huge mass that displays the stomach to the right side of the abdomen, as shown by these green arrows, and a lower cut showing a huge mass displacing all of the bowel loops to the right side of the abdomen as well. Another cut of the mass showing the mass is very huge in the left hemi-abdominal compartment, as encroaching, accuting the pancreas and the splenic vessels, as shown in these arrows. And this is another cut which shows the mass have areas of necrosis and cystic degeneration in its interior. And this cut of the mass showed the mass as it appears in the aorta and the left renal vessels, and it goes to the left kidney. And this cut showed the mass partially infiltrating and lateralizing the left side of the colon, displacing it to the lateral abdominal wall. And we can't imagine how huge the mass was until we see these coronal cuts of this mass occupying more than the left hemi-abdominal compartment and displacing all of the abdominal content to the right side of the abdomen. An exploratory laparotomy was decided, and during the laparotomy we discovered a huge lobulated mass. We showed a huge lobulated mass that arose from the root of the transverse mesocolon, and it was locally infiltrating the corresponding part of the colon, namely the lateral 1/3 of the transverse, as well as the upper 1/3 of the descending colon. And we used a ligature to dissect the mass from the surrounding, from the stomach, from the pancreas, and from the aorta and the left renal vessels as well. And left hemicolectomy, along with primary colonic anastomosis after resection of the mass, was done with covering ileostomy because of the colon that was badly prepared because of the partial obstruction by the mass. The green star refers to the colonic segment that was resected along with the mass. Post-operative course was uneventful, with the patient spent 1 day in the ICU, and he was discharged on post-operative day 5. The specimen was sent for pathological analysis, which grossly revealed a 30 per 28 centimeter long mass that was partially encapsulated and arise from mesentery. And the colonic segment, it was normally apart from the patch of infiltration of the mass, as well as a small side polyp that was less than 1 centimeter in diameter. The dissection of the pericolic fat revealed 16 lymph nodes. And we wait for the microscopic analysis that revealed a diagnostic dilemma of a mesenteric mesenchymal tumor. The first slide on the left side of the image, showing a spindle-shaped growth that was described by the pathologist to be in a story-form arrangement with an intervening collagen in the slide B, which is the upper right corner of the image. There were uniform areas of lymphoid areas, as well as scattered mitotic figures and foci of interstitial hemorrhage, and the mass was proved to infiltrate the serosal vault without direct infiltration of the muscle vault of the bowel. And we professionally performed an RZ resection margins. All the margins was free from the tumor, and lymph node reactive hyperplasia. And we face a tumors that start with the guest and go with a long list of other types of sarcomas. We requested immunohistochemistry panels that showed primary negative staining of the tumor cells to the CD34 and CD117, which exclude most probably guest tumor, as well as negative staining to the smooth muscle actin, to the S100, desmoid, calretinin, which most probably excludes other types as neuronal tumors, melanoma, myofibroblastic tumors, as well as mesothelial tumors. Based on this panel, the pathology, the initial diagnosis was revealed in favoring an adult fibrosarcoma, adult malignant fibrosarcoma, not otherwise specified. However, after being discussed in the MDT meeting, another extended immunohistochemistry panel was requested, and this panel include vimentin, beta-catenin, which revealed diffuses cytoplasmic staining of the tumor cells of the vimentin and diffuses strong nuclear staining of beta-catenin. As well as the Ki-67 proliferative index was requested that shows that nuclear staining of about 10% of the tumor cells positive to the Ki-67. Based on these panels, the diagnosis was changed, favoring mesenteric fibromatosis, and the final diagnosis was concluded to be mesenteric desmoid fibromatosis that arises from the mesentery of the transverse colon based on the extended panel of the immunohistochemistry. The patient has an eventful closure of his loop of ileostomy after 2 months, and post-operative colonoscopy was free, and this concludes a case of sporadic non-fab mesenteric desmoid fibromatosis as a final diagnosis. And according to the NCCN guidelines, the patient underwent an RZ resection margin, so he went for observation and to be monitored for symptomatic progression, and the patient was closely followed up clinically and radiologically every 3 to 6 months. We are now about 5 months post-operative. Here I'd like to review some issues and highlight some important points about desmoid fibromatosis. According to the WHO definition, it's a clonal fibroblastic proliferation that arises from the deep soft tissue. And due to its local aggressive infiltration and highly destructive nature and high rate of recurrence that was described by the authors to reach up to 80%, it was classified as an intermediate malignant tumor. It has a very low incidence of 2 to 4 cases per million per year, and etiology is largely unknown, but there are some predisposing factors, genetic predisposing factor approved by its association with the FAB and the Gardner syndrome, and hormonal theories was proved by its duration by pregnancy, and physical factors as previous surgery may play a role in the predisposition for desmoid tumors. Immunohistochemistry pattern suggestive of desmoid tumor as described in the literature. It's most commonly positive to beta-catenin and vimentin in 95% of the cases. Muscle-specific actin and smooth muscle actin are sometimes positive, and very rare tumor cells showing positive staining to the desmoid and S100. According to the anatomical size, desmoid fibromatosis may arise extra-abdominally, mainly in the proximal limbic girdles, more than 60% of the cases. 25% of the cases arise from the musculonephrotic abdominal wall, mainly the transverse abdominals and the internal oblique muscles, and it's most commonly associated with the pregnancy, and it flare in the females and flare up with the pregnancy, and it can occur intra-abdominal in less than 10% of the cases in the pelvis or in the mesentery, with a small bowel and spinal mesentery is more commonly affected than the large intestinal mesentery as in our case. According to the biological behavior, desmoid fibromatosis was classified as the sporadic type and the FAB-associated types. For the sporadic type, it's most common. It constitutes more than 85% of the cases, in contrast to the FAB, which is less than 15% of the cases. However, to be noted that FAB patients have an increased risk of desmoid fibromatosis, more than 800-fold risk, and it was described to be 1,000 by some authors. Sporadic desmoid fibromatosis, it occurs mainly in an extra-abdominal fashion, 95% of the cases, in contrast to the FAB that occurs mainly intra-abdominal in more than 80% of the FAB-associated desmoid fibromatosis. The pathogenesis of the desmoid fibromatosis is related to a somatic mutation in the CTNNB1 gene, which is the gene coding for the beta-catenin protein. the main protein associated with the pathology of desmoid fibromatosis. However, in the Fab-associated desmoid fibromatosis, there is a mutation, the adenomatous polyposis coli gene. It is one of the genes that are responsible for decreasing the intracellular amount of the beta-catenin in the cells and supplies the beta-catenin protein and decrease the risk of encroaching the desmoid fibromatosis. I'd like to know the molecular basis that is related to increased cell level of the beta-catenin, as I just mentioned. And the beta-catenin plays a role intracellularly to induce the transcription factors in the nucleus, and regulated and increased intracellular beta-catenin increase the transcription factors in the nucleus and favor the tumorigenesis intracellularly. The beta-catenin is regulated via one beta-catenin dependent pathway. When are growth stimulatory factors? When overstimulating the cells, it increases the intracellular level of the beta-catenin. So the hallmark of the disease is an abnormally stable beta-catenin protein in the Fab-associated, as I just mentioned. The abnormality is in the adenomatous polyposis coli gene, which is one of the phosphokinases that inhibits the beta-catenin and prevent its increased intracellular accumulation. While in the sporadic type, it's a somatic mutation for the gene encodes for the protein, rendering an abnormally stable beta-catenin to phosphorylation and thus increased the intracellular levels of the beta-catenin protein. Desmoid fibromatosis is an enigmatic disease with a heterogeneous and variable natural history. It was described in 1995 by Church to have an unpredicted response, with 10% of the cases resolve spontaneously, 13% have cycles of progression and resolutions, 15% remains stable, and 10% may progress rapidly. Another study in 2014 by Go et al. In Chinese population revealed the same clinical cause of desmoid fibromatosis. However, he reported that no cases in his series reported spontaneous regression. For this cause, as well as the scarce data about desmoid fibromatosis, it's very low incidence and unpredictable response, and most of the studies applied to desmoid fibromatosis are as prospective studies. Management options are always challenging and mainly based on individual cases. Management options include watchful waiting, local therapy, surgery plays a role, radiotherapy alone plays a role, or surgery therapy was described by some authors. Systemic therapy was also documented, and some authors are now repeating the role of the systemic therapy alone in regressing some cases of desmoid fibromatosis, but still case reports about this issue. The examples for systemic therapy include non-steroidal anti-inflammatory drugs, hormonal therapy, and systemic chemotherapeutic regimens. It's a standard of care now that the surgical resection was establishing R0 margin is a standard of care for managing desmoid fibromatosis. However, the R0 resection margin, due to the aggressive nature of the tumor, is not always established without significant morbidity and even mortality. And so it was also described to have function-sparing resection with positive margin. However, Baruch et al. 2016 released that 10-year recurrence rate in patients with positive margin is double than the patients with negative margins, as you know. I'd like to conclude that mesenchymal intra-abdominal tumors are an issue of diagnostic dilemma, and the immunohistochemistry panel studies are cornerstone for its diagnosis. And although uncommon desmoid tumors should be considered in the differential diagnosis of the abdominal swelling, other differentials include a long list of mesenteric sarcomas and mesenteric mesenchymal tumors. Beta-catenin is strongly positive in desmoid fibromatosis, and we think it's essential for diagnosis. And revising pathology in an MDT setting is crucial in correlation with the clinical data, and this may change the future management plan of the patient. Standard of care in desmoid fibromatosis is surgical resection with negative margins, establishing R0 resection margin whenever possible, but it's not always possible because of the aggressive infiltrative nature of the disease. Desmoid fibromatosis is an orphan disease due to the very low incidence of the disease, so it's mandatory to include as many patients as possible in clinical trials that include other lines of management and stand on the best standard of care for this tumor, for this disease. Thank you.
Thank you, Dr. Mohammed Shawi, for your elegant review of this case report of desmoid fibromatosis. Now the floor is open for any question. Any question for Dr. Mohammed?
Yes? Yes.
Thank you, Professor. Can you find that the sporadic cases has the notorious pathway in beta-catenin? And beta-catenin is known as one of the genes responsible for metastasis. And how can you explain why it is mutated, but this is a local?
Yeah, beta-catenin, let me revise a slide here to illustrate this point. Beta-catenin protein is a cytosolic protein as well as a protein that's involved in the E-catenin, which is involved in the cell-to-cell adhesion molecules. And when beta-catenin levels are increased markedly, it induces transcription factors in the nucleus as well as dysregulate these adhesion molecules between the cells and thus favoring the tumorigenesis. I hope that I responded to the question. So,
you explain how the beta-catenin leads to dissociation of cells.
Yes.
And the inhibition of adhesion.
Yes.
And this is the first step in metastasis.
Yes.
Right? Why does it happen metastasis?
I
don't know the answer. I don't know, but I'm just.
Yeah, this opened an important question, but I'm not sure about the.
We need to read it. Maybe this is another pathway.
Maybe there is a specific mutation in the gene encoding for the beta-catenin molecules what affect the tumorigenesis intracellular, affects the transcription and the RNA polymerase intracellularly, thus favoring the tumorigenesis in a local fashion rather than in a metastasis fashion.
Okay. Anyway, beta-catenin also involved in nasal cell carcinoma and it's also non-metastatic. Yeah, what we need to. Thank you very much.
Thank you.
Thank you, Dr. Mohammed, for this very nice presentation and very thoughtful I'd like to ask Dr. Mira what is the meaning of desmoid fibromatosis?
What was?
The meaning of desmoid.
Terminology.
Terminology.
اسمح لي دكتور محمد؟
اتفضل.
من حوالي 100 سنة بالميكروسكوبات المتاحة وقتها كانت فايبروما يشيلوها ترجع. طب هو في فايبروما بترجع؟ بناين تيومر. فاللي وصف الوصف ده باثولوجيست اللي هو باجت. قالوا له خلاص هنسميها على اسمك ريكيرنج فايبروما اوف باجت. مفيش فايبروما بترجع فهنسميها على اسمك. دي أول تسمية. بعد كده المقطع اوزس يعني excessive formation of اما بنقول adenosis epitheliosis الى اخره. اوزس means excessive formation of فهي excessive formation of fibroma فالنطق كان المفروض فايبروما اوزس بس صعب فحطينا حرف تي ما بين الاي والاو فبقى فايبروما توز مش بس ننطقها لكن هي فايبروما اوزس. اخر حاجه ديزمويد اويل لاحقا معناها يشبه او in the form of وديزمو من ديزموس in Latin means tendon. It is tendon like تشبه التندون تشبهه في ايه؟ tough fibrous tissue whitish in color. This is the origin of fibromatosis and desmoid tumor.
Thanks, my dear professor. I think he illustrates that I would illustrate more. Thank you.
Happy to announce that there is another presentation by Professor Hussein Tahri from Asyut about the problem of mesenteric preservation in low rectal cancer with controversy in distal resection margin.